Appreciate the folks on. All right, welcome back. And I'm glad to welcome some new folks to our policy roundtable portion of our meeting. I think we have a slide though with everybody's name, if we can just show that. Great. So from the morning sessions, we still have our patient and clinical experts. That's Dr. Bimraj and Linda Goler-Blount and Ed Mills. So we have some other folks here representing other perspectives and organizations. So let me just run the list here and ask them to briefly introduce themselves. And if you have any conflict of interest, obviously we have it shown here, but anything else in particular, please mention it. So Sri.
Hi, everyone. My name is Sri Jagatiru. I'm internal medicine physician, and I'm the interim chief medical officer for CVS Health.
Thank you very much for being here. And Jim Curato.
Hi, everyone. Jim Curato, Vice President of our Integrated Account Management here at Merck. So I lead all of our payer engagements as well as all of our distribution of our products through the wholesalers, specialty, et cetera, and all our channels.
Great. Now, I'm not sure we have Mohammed Dar. Oh, there you are, I think. No, maybe not. I mean, we've got Mohammed Hussein and Mohammed Dar. I'm just wondering, is Mohammed Dar with us yet? If he's not, I will skip to Mohammed Hussein.
Yes, hello. I'm Mohammed Hussein. I'm a Senior Director of Health Economics and Outcomes Research at Regeneron, and happy to be joining you, and thank you for the invite.
Thank you for being a last-minute addition. I think it's nice to have you on. And Mary Roberts.
Hi, I'm Mary Roberts from GSK. I'm the Vice President of U.S. Market Access Strategy. I'm happy to be here, and thanks for having us.
Thank you. And Mohammed Dar, who's also, Modar is also, we've had you on our calls before, so thank you for joining us. Do you just want to briefly introduce yourself?
Sure thing. Good afternoon. I'm Mohammed Dar. Friends call me Modar, Senior Medical Director at Mass Health, the Massachusetts Combined Program for Medicaid and Children's Health Program.
Great. So what we've got is a great mix of people with perspectives from the clinical kind of side, clinical trials, different kind of diverse low-income communities, and obviously also folks from the kind of innovative life science side here, and two payers, one from Medicaid and one from the private insurance side. So just so you guys know how I've conceptualized that next hour and a half, I wanted to kind of separate my questions in our discussion into a clinical kind of set of questions. Then I think we're going to spend a fair amount of time talking about distribution, delivery issues, the test to treat kinds of questions, and then saving some of the more, I think, always interesting considerations around pricing and contracting, both in the I guess you could call it the governmental phase, and then ultimately in the phase after the governmental contracts expire and we're looking at the future. And we'll have I'm sure some other side conversations or questions that we'll take in different directions around research, other things that might go forward. But I think I'll start first talking to the clinical kind of experts, and that includes Ed as well. Obviously, and this is a question about guidelines. We're not here to make guidelines, but I do wonder if you have a comment around whether we are managing guidelines in the US well. Now, Adarsh, you have a vested interest because you've been fronting the IDSA guidelines, but just the other day I tried to just kind of scan around, and the NIH has guidelines, CDC, those two kind of talk to each other. But you go to the states and they have guidelines that are more or less based on the NIH or the CDC guidelines, but often vary a little bit. And if I'm just a provider out in the community, and I'm sorry, I didn't even actually check the IDSA guidelines, they're probably online too. But are we managing the guideline process well? Any suggestions? Because we're ultimately hoping to make either perspectives on current policies or policy recommendations for how we might improve things going forward. So let me start with Adarsh. How do you view the guideline world and whether we're managing it well?
Steve, that is a great question. So last week we had 2 full days of a meeting with ASP, the Assistant Secretary for Preparedness, on how do we do guidelines. This was all government. We could do a much better job. And I'm being honest with you. I think the reason I say is guidelines from the perspective of who, I think that was the big part of this whole discussion. The stakeholders are so different. Am I doing it from the perspective of an individual practitioner in a family practice? What specialties am I dealing with people dealing with a policy level at an individual hospital or at a state level? So what is the scope of the guidelines? And I think that was the biggest discussion. So each of the audience is going to be different. Ours was a clinical practice guidelines, which was directed towards an individual clinician, and so is NIH. And even us, I think clinicians don't think in terms of PICOs or the totality of the information. How do I make the right diagnosis? How do I test? How do I treat? I think we fall woefully short about delivering stuff that a clinician needs in the language that the clinician does. So I think I'm dealing with the negative. So I think that is something the guidelines should take into consideration. But the bigger perspective is, should be a different piece taking policy at an individual hospital or practice level into consideration of the guidelines as outcomes, not just as patient outcomes. Because whoever I talked to found that the guidelines fell short in helping them decide. Probably that's where the niche where you guys come in, is making decisions beyond just individual patient outcomes, factoring them into policy decision makings.
Interesting. No, thanks. Ed, any perspectives that you have? I know you're ex-US, so you may have seen how guidelines are done either in Canada or other countries, God forbid those with actual health services and public health systems that function well. So, but have you seen any best practices, or have you also felt like you've been stumbling a bit?
No, absolutely, Stephen. I've been in touch with people with the guidelines in Australia, within Lebanon, and I'm constantly in touch with them. One of the issues I realize, I'm sure Ed can comment on it, is we work in silos rather than work together. And I'm not even talking about guideline panelists, but what should be the outcomes? People are generating evidence who are doing these platform trials versus people are synthesizing evidence. People are doing their analysis versus people are making policy decisions and individual guidelines. We don't talk to each other. We don't communicate each other. Maybe it is the lack of time, lack of resources, but I'm hoping in the future, even this policy, what we can actually communicate so that whatever we communicate is in sync. I think, and that is a common theme when I talk to people in Australia, in other guidelines, they're thinking, I wish we all as a community collaborated better so that our work, whatever we finished, were complementary rather than contradictory and confusing.
Okay. Ed, thank you.
Look, I fully agree with Adarsh. And I have to say that today is the most open discussion that I've observed yet of anything that could resemble public advice. So, as somebody who runs trials, I run trials, then I get asked specific questions from guideline committees, give us this. And I will often say, sure, but should we have a discussion about this so that, you understand context, et cetera? No discussion, give it to us. All right, well, and then they're going to be, let's say, systematic reviewing it and prepping it for guidelines. So there's no discussion between the trialists and the systematic reviewers for no reason whatsoever. And then those systematic reviewers hand it off to guideline decision makers. And for slightly better reasons, there's not that much communication between them. But as Adarsh points out, I think we don't work in symphony with each other. One of the advantages for companies that own a molecule, as opposed to someone like myself doing academic work where I don't own any of the molecules, is that the companies can talk to their basic scientists, their market access team all at the same time and line things up for better preparation to release the message. And I think that's a great advantage. And in many ways, us in academia really need to learn a lot from industry about packaging our messages. Another aspect of doing trials is, I was always under the impression when you do a trial, it was to create evidence, and then someone else would take that evidence and turn it into policy. And what has been very clear during COVID was, I do a trial and then I get asked by WHO, Gates Foundation, you name it, so why is this not yet approved? did you submit an EUA? Well, that's not my job. My job is to run trials. But as it turns out, maybe my job is to do something more than that. And I hadn't, up until COVID, not been aware of that. The final thing I'll say on guideline panels is that although I'm not on a guideline panel, I work with a fairly open collaboration of all people running outpatient trials for COVID. Everybody's welcome to do it, to participate. WHO hosts it, I think it's once a month or twice a month. Mm-hmm. And we are all frustrated running trials when the endpoint that's still requested is something so rare, hospitalization, which is only occurring in, 4 or 5% of very high risk patients. What all of the outpatient trials that I'm familiar with are arguing is that the outcomes of interest at the moment have moved closer towards what the patient may desire, like return to work, feeling better. Did they ever have to go to the hospital, let alone were they overnight hospitalized? And because there's no discussion between the guideline groups and the trialists, there's a frustration among the trialists that we're not being heard, that the trials are becoming much more difficult to conduct, but we're still being asked to deliver on something that is so rare that you end up needing massive trials. So you'll see, for example, the panoramic trial in the UK right now, which is testing molnupiravir versus standard of care. They, when molnupiravir first got tested, it was what, 1,500 patients? Then that 3 or 4 months later, with high rates of vaccination in the UK, they planned for a 10,000 person trial. They're now at 20,000 patients. Now I don't know the results, but I do have a sense that they're not detecting enough clinical events. And those same investigators have been burned a little bit on that issue of what is the outcome of importance. So they're chasing that outcome for a guideline panel, and it's gone up almost 15-fold. Anyway, that's my 2 points.
So I want to circle back. So I want you and Adarsh to think of, if you were king for a day and the job was to fix the process for designing guidelines in the US, and I'll be nationalistic about it for now. What would you do? Would there be a superstructure? Would you appoint one of the entities to be the keeper of the guidelines and everybody feeds into them? What would you do? So think about that for a sec. But I'd be surprised if the manufacturers haven't had their own experience, certainly thinking globally, but even in the US, as you see these different guidelines being created, what would best look like from your perspective? One major national, one source, one size fits all? Would you subdivide up the system? What would you recommend? And I'm open to any of the manufacturers jumping in on this. Did I ask a sensitive question?
I think you asked a more clinical question, probably by commercial representation here. But Steve, I'll answer it this way, right? I think the challenge of one guideline that is universal, whether it be across, around the world or even across an individual country, is populations are very different. And we've seen that, throughout the COVID pandemic, whether you look country by country in terms of the rates of infection, the transmission of infection, the recovery from that infection, and then even within the US, when you look at communities of color and others where there's been disparities in who has either access to medicines or just comorbidities and the relative impact on that. So I'm not sure how one guideline covers all of that and provides clarity in how everyone should then subsequently treat.
Okay, I will say one thing as I guess for some reason I'm still on the list of clinicians who receives updates as if I were going to be prescribing and treating patients today. But I've been very impressed. The state of Massachusetts, every week I get a single email that has a clear update. And what's nice is that I know it's recent, I know it's been updated. And if I were practicing, that's probably what I would rely on. Maybe if I were in a group practice, we would have a different approach to centralizing the process. But it's a pretty effective way of getting to me. But I went looking on other states' websites and I couldn't find the same kind of information in the same format. And every state seems to do it differently. And then we've again got the NIH playing an interesting role here. Just historically, I was surprised that the NIH had a clinical role in coming up with a guideline at all. Let me flip it over to the payers too, though, because you guys are in a sense also avidly watching guidelines, because from a payment, from a coverage and payment process and delivery also for SRI, you guys have to know what the feds are saying should be the way that care is done. How would you, do you think that the current guideline system is working well, or how would you want to change it if you could?
Well, we're less as a payer, and again, just to orient folks to CVS Health, think of us as 3 business units: Aetna with healthcare benefits, our retail pharmacy, and our PBM Caremark. So I'll be talking about the Caremark and the Aetna benefit side, and I think Steve at a later point we can talk about pharmacy. But from a benefits perspective, much of our criteria development is based on label, and so the evidence generation goes into the generation of the FDA label, and then we would determine our coverage criteria based on that. These are not commercial markets at this point for COVID. So, we're covering all of these, and then just, when we're creating criteria, and, I will say from a CVS Health Caremark perspective, we're hesitant to create any criteria that would slow down the ability for somebody to get necessary therapy. So we really want this to make sure that, especially early on in the pandemic, when there was more supply issues, that we're ensuring that the right patient got the medications, that we didn't disrupt, that people who didn't qualify for the medication didn't necessarily use the medication at the expense of somebody who needed it. So, as we developed out these criteria, we tried to do them in a way that was based off the label to make sure that only those who are indicated by the label would get it. When this moves into a commercial, marketplace, let's say there's multiple vaccines or multiple oral antivirals. I think Ed brought up an important point, which is like right now in these trials with the low event rates, it's hard to actually distinguish, between one agent versus another. And so, we're still a little bit of ways away from this being commercially negotiated, since most of this is being purchased by the federal government. But what we'll need is evidence from manufacturers that we, or from independent investigators, that we can take to our P&T committee to evaluate, should there be options? Should we try to create price competitiveness across products in a class, or is it wide open? And then, we wouldn't have competitive dynamics, and there's issues on pricing when you think about it from that perspective too. So
good. Yeah, I'm going to come back. We're going to circle back to some of that aspect of the future in which, as you said, there'll be different issues like negotiation back on the table, perhaps. So, but you're hearing, the rest of you, you're hearing from a payer perspective, certainly in the short term, what the absolute language in the FDA label dominates kind of the process of marching that into coverage. Guidelines are kind of a trailing factor in this kind of situation, whereas at some point in the future, if the pressure is off and there are multiple options, then guidelines might start to play a bigger role. And actually, before I go back to the clinical experts again, who get to change the world, let me ask Linda to comment, because we think of guidelines, and maybe it's too easy for me as an ex-clinician to think of clinical guidelines for doctors and other healthcare providers. But how is the country done? Do we need a guideline for patients? Do different communities need different kinds of information? Should it look like a guideline? What do you think the country has done well and really could do better?
Yeah, that's a tough one. As I'm listening to what folks are saying, with part of the problem with guidelines is how they're communicated or not communicated. You're in a great situation. You get an email. I'm going to guess the average rural doc in an FQHC or small community hospital is not getting that kind of email, particularly not too far from where I am in Georgia. So we leave it up to docs to make some decisions, which then, by definition, as we know, introduces bias into how patients are treated. So without clear-cut guidelines, we create more bias, we create more disparities. What would be great is if we could look at the data and come up with guidelines that make sense for certain populations. I mean, in all of the data that have been presented today, obviously race, ethnicity is lacking in these studies. We don't have data by socioeconomic status, which also matters. Geography matters because what you get in New York is going to be different from rural Georgia. So there's a lot that could influence guidelines if we collected the data and then did the appropriate analysis. But even then, we have to be really careful about how they're communicated and how they're interpreted, because you don't want to run the risk of introducing bias. And I think Stacy was kind of getting to this. There's an old saying: effective technologies are always disparities producing, because certain people get access to them and certain people don't. And so that has to be considered when we're thinking about guidelines. Who's going to get access to what effective therapeutic, and how do we communicate it to make sure that those who need it actually get it?
Well said. Well said. Okay, and we'll come back to some of those aspects soon as well. All right, we have already 20 minutes into a conversation that could be an 8-hour meeting, clearly, and I'm going to force us through some issues where we haven't even had the chance to kind of dive deep. So I want to go back, though, to Ed and Adarsh. Let's assume that this final report has a recommendation or two about the role of how best to link clinical trials through to clinical guidelines in the U.S. context. What would be best? Adarsh, what would you do?
Steve, again, no, this is a great discussion. I hate to sound like a geek, but I dream about this. I breathe about this. As I'm not just talking about clinical trials to clinical guidelines. Let's go the next step: clinical practice and patient suffering. Right at the end of the day, what use is a guideline if it doesn't translate into that? So, and I think the problem is with evidence generation, evidence synthesis, writing guidelines, as well as seeing that they follow. So the first step, I'm going to say, Steve, in an ideal world, if I was king and if this was John Leller's song, Imagine, I hope the outcomes, like for vaccines, are defined upfront, whether it's the FDA, whether it's some other organization. For mild to moderate COVID, what are meaningful? Involve stakeholders, especially patients, as to what is meaningful to them, and universally apply the same outcomes. And also variables. What are the effect modifiers? Is it race? Is it something else? I know upfront in a pandemic, it's really hard to predict which way it's going to go. But come to think of it, we did that for vaccines. Why couldn't we do that for treatments beyond COVID-19? So that's figuring the outcomes and the variables and universally applying them. And in terms of guidelines, not individual PICOs, I think that's great. But like the economic prediction models, what if I'm a clinician, I go on, I have an app, I put in the baseline risk factors and say, if I give molnupiravir, what will be the absolute risk reduction in my patient and what the risks? At the end of the day, your 150-page War and Peace Leo Tolstoy guideline is not going to be read by any clinician. It has to be made into a decision tool that is interactive and that can be used. I think I can go on, but I'm hoping guidelines will actually go in that direction. But that's a lot of work and that's a lot of collaboration.
No, it is, but it's possible. I'll just briefly note that absolutely some of the state websites where you, as a clinician, you go in through that portal, all you get is information. I'll use that term as a negative. You get information kind of just thrown at you with links to go other places. Whereas some sites lay it out like a mini guideline where they say, first consider Paxlovid, and here are the considerations. If you can't use that, then here's second. It's like, a real kind of stepwise guideline in a sense. Now that level of specificity makes people nervous to a certain extent because it will start to drive uniformity and maybe lose nuance of shared decision-making. But on the other hand, as a clinician, sometimes you need somebody just to tell you what to do. Ed, what would you have us do about guidelines?
Yeah, so I wish I had a recipe for success right away. But what I really think is that COVID has exposed how completely disorganized we are in every aspect of medical research. And so whether it is trials where people don't know how to recruit or they choose bizarre drugs to put in there, the total lack of funding that goes into that, systematic reviews and the strange supremacy that they seem to have in decision making. And then, of course, the economic elements, which differ according to a variety of things like geography. Who are you really thinking about? is this truly US focused? Is it for other countries? My preference is something that's more international. And I've voiced that to you, Steve, as you know. So, we all come to it with different values. I definitely think involving patient groups in determining what the outcomes are is probably a moving target. And so there's a need for continuing involvement of them, which I haven't seen an awful lot of. And maybe Linda can tell us if you felt that there was any involvement or continuing involvement about this issue. On the other hand, I think we have to be careful about involving too many groups because there's crazy groups out there too. And so when we are coming up with guidance for guidelines, it needs to be agnostic to the interventions that are being tested. The fact that outcomes tend to be moving targets should make a lot of sense because, when there's no other treatment for something, you want, and something is very rare to get your hands on, that's one element of risk in terms of what risk you're willing to take for a drug and the cost that you're willing to pay for it. But right now we have a whole bunch of interventions coming along that are all probably going to get priced around the same point, and they all kind of do the same thing. And what we're seeing then is we're 2 years into this, and I predict in 6 months or something like that, we'll be inundated with biotechs, with technologies, molecules that work for early treatment of COVID, work for hospitalized patients. And that's where biotech has gotten to, that's where pharma, because they're always constantly thinking in the moment. And really what we need to be thinking about is broad spectrum treatments that are going to be applicable, because we don't know what the next variant is going to be like. There are drugs that come out, was it Adagio last week had I think it was a single dose injection that showed a very nice treatment effect, but the last patient had been recruited in December or something like that. And the response from the community, the medical community, has been, well, we haven't shown it in Omicron. And so very little interest in this intervention. But, we don't really know that Omicron's that different. And I do believe some of the drugs we've talked about today work the same under very different variants. And of course, what do we even mean by a variant? Because a variant is a complicated issue. So all of that's to say that I think there needs to be humility in our decision making, where we admit we don't really know everything. And for that reason, we need to have greater discussion, and particularly when whether it's a drug company or a trialist or someone says, I think you've interpreted this wrong, then the guideline committee needs to have a way for communicating these issues.
All right. Got it. Okay.
If I was king of the world, I'd stop the war right now.
If you were king, you'd assign a mandate of humility. All right. As king, you have that power. All right, I'm going to skip through some of my really interesting questions to move on. And Ed, I may come back to your recommendation perhaps on whether the FDA needs a new kind of outreaching consultancy to work with academics looking at repurposed drugs in a pandemic, whether they need to help that EUA process work in some different way. So think about that in the background while we move to talk a bit about distribution and delivery. I made some notes here based on things in the public domain, but much to some of the way that we've been talking about the challenges, the evidence on the early use of monoclonal antibodies from November 2020 through April 2021 showed that only 7% of non-hospitalized Medicare patients with COVID-19 received monoclonal antibodies. And the patients who were actually at the highest risk of severe disease within that cohort were the least likely to receive antibody therapy. That was in an article in JAMA published in February of 2022. So now we're talking mainly about the orals. So we've had this experience with monoclonals. We've got the orals now out there. And interestingly, in January 2022, all the articles about distribution and delivery were about the shortages. The distribution of a rare, kind of how are we getting Paxlovid? There aren't enough. Where are we sending it? Should it go directly to pharmacy? Should it go to hospitals? Everybody needs it. Nobody has it. And now we're in a situation where I think people think that it's sitting on the shelves. But I do want to talk about the scarcity situation, because that could come back again, either in this pandemic or a future pandemic. And I wonder, did we learn anything about the distribution of these treatments, everything from the monoclonals through to the orals now, when they're in short supply? What did we learn that we could say would be a better way to do it the next time around? When there is scarcity, what does the distribution look like? Who gets to decide? Who gets it? What's the right way to organize it? And again, I would think that some of the manufacturers, especially of the monoclonals, might have had some experience thinking through this. Any comments on what we learned from distribution to do better?
I don't know if Mary, you want to comment first from a monoclonal standpoint.
Yeah, I'm happy to jump in. I mean, I think the the distribution model that we were presented with was through the federal government, right? So sotrovimab was available commercially before it was brought on by the federal government. I think it's difficult to, knowing that complexity, it's difficult to respond to how we could do it better, because that has been our experience thus far, and because of the emergency use authorization.
Do you think it worked well, though?
It's difficult to say. I think we were not, we weren't looking at the distribution, at the state level. We were just looking at the distribution through the federal government, and then those allocations were made at that level.
Others, go ahead, Mohammed.
Yeah, sure. So we have to, as Ed before said on the humility issue, we have to learn that this something was new to all of us. So it's not something that we have faced before at that scale. And as a result, many of us been learning on the go on what is the best model. And maybe we could acknowledge that things were a little bit difficult earlier when monoclonal antibodies were available. But over time, we'll learn, and that's the most important part, we'll learn where the gaps are and we start to fix them. For example, establishing centralized places where people can go online and find out where is the nearest administration center that they can go to. So I think leveraging technology is an important aspect, which is, I believe, could be advanced and used in future pandemics. Also, one of the learned lessons is the continued dialogue and being open-minded when you find gaps and be willing to fix them. And I think that's what we've experienced through the pandemic. So these are the two key learned lessons that I believe, hopefully, in the future we'll avoid them.
So would both of you vote, and Jim, you can weigh in on this too, would any of you vote for a different approach for the role of government in the distribution of these treatments in a pandemic when there's a scarcity of treatments to go around? Should the government be in charge, and any difference in the way that process worked from your perspective that would be better next time? Jim, go ahead. You can weigh in on that. Or
yeah, so, boy, talk about a barbed question. I should have answered the other one and not and straight away this one.
Go ahead, criticize the government, Jim.
Yeah, exactly. Remind me again, these comments will not be directly attached back to us, right? No. So I think the lesson learned, Steve, right, is a little bit to where you're getting, which is there is a tremendous value for government as purchaser in these situations of a pandemic, right? The immediacy of making product available to the population was a critically important component in this. It does raise question around the government and its role and its practices in the healthcare chain relative to other purchase and distribution that it might make elsewhere from a government as a purchaser, right? And so I contrast that with maybe it's military supply or other, right? So just to take a very extreme example. And the reason that I say that is because some of it starts with what are the definitions that the government is using, and then what are the practices that follow those definitions? So for instance, scarce resource or scarcity of a resource, how is it being defined? And I think some of the comments that you raised early on, right? 7% of people who were perhaps in need of a monoclonal antibody were actually administered a monoclonal antibody. That falls under the assumption that 100% should have gotten it, would have gotten it at all, right? And so if you say scarcity says 100% of the population needs it, and I only have, let's say, 10% available upon immediate approval of an early use authorization, then you're going to say perhaps this is a scarce resource. But if you say, right, that this is a resource and you follow what I would call normal practice around how is this product going to be used? Who is this product going to be used for? What is the timing in terms of immediacy of access or need for the product? You might come to different conclusions. And I say that because a lot of the early experience with the monoclonals is what was applied for the oral agents. And when you think about the utilization of the oral agents, it was a very different dynamic in who was potentially going to prescribe, where that prescribing was likely going to occur, what was the necessary timing to administration, from timing of diagnosis to timing of administration of the product. And so there's a variety of variables that unfortunately things went down a bit of a one size fits all, I think. And I think that's a big learning here, right? Is what are the definitions? What is the treatment of the respective disease? What is the utilization of the method or other, right? And if you think about even going back to the original distribution was around vaccines, and that was arguably, one could argue, a much easier path forward because the volumes exploded very quickly relative to the anticipation of them coming. On the treatments, the expectation relative to the availability of them was very different. So again, just different dynamics that we have to think about, different modalities.
Adarsh, let me come to you in one sec. I wanted to get Modar's perspective, if you have one, because if you can remember back to when you were trying to figure out how to get monoclonals for patients on Medicaid, how did the distribution system work? What was the government's role, both at the federal and state level? And do you think there are any best practices that you would tease out?
Sure thing. Even in the conversation we had around guidelines to begin with, this pandemic, we know it, it's been atypical compared to any other guideline making. There's so much whiplash. Monoclonals that were working one season, the next season, they're not. And I think we need to take lessons from this. We also got to give ourselves a little bit of credit because the systems were not designed for this, and therefore we have onus to do better on this. I think where governmental systems work well, where distribution systems work well, is where everyone is communicating, talking, and not in silos. So Steve, you get that same email I do from Mass Department of Public Health about the latest guidelines. I speak with Department of Public Health about what is coming in from that, making sure that, like for Mass Health, Medicaid, our payment systems are online for the newer monoclonal or the newer drugs coming online, that we are adjusting as well for those that won't be effective anymore. And as far as the uptake, I think it is as much distribution, but it is also making sure that we still have the public trust. I think we had a number of treatments hyped, especially in 2020, that turned out not to be the case. And so as a frontline clinician too, it's harder for me to convince the patients that, no, it's this monoclonal or this thing that's the actual thing that works, especially if for a monoclonal, you're talking about keeping them in the clinical space for an hour or two. So I think it is coordinating well. It is bringing the information to be as consolidated as we can in light of supply chain resources. But then it's also making sure that we're doing our best with the trust that we have.
Great, thank you. All right, let's run the gauntlet here. Adarsh, then Linda, then Sri. Adarsh, go ahead.
Again, I'm speaking as a frontline provider, Steve. Again, before we even ask ourselves, how do we distribute? Should it be distributed? I think why casirivimab, imdevimab, why not sotrovimab, right? Again, upfront, why did they do for hydroxychloroquine? My pet peeve with the FDA AUA process or with the government is like, did they have an evidence profile? Did they have the stakeholders? Like, what is the analysis of the evidence? And from there, the evidence to decision framework or cost analysis, I think that step would have been instrumental. Like Jim said, that money could have been used elsewhere. Or who knows, maybe that's taxpayers' money, that's bigger inflation. Again, I know I'm going beyond, but even from a clinician point of view, that process was not transparent and explicit as to why a drug is being made available and why other drugs are not being available.
Yeah, I mean, every once in a while, we'll say to ourselves, we should cut ourselves some slack because it was everything's been hard and different and unpredictable. Policymaking has been like flopping around on the floor like a dead fish or a dying fish at times. So it's not always pretty. But again, I think I think we will learn that some things went better than others. So you're right to reflect that there were some aspects of that early decision-making that deserve some historical scrutiny, I hope, at some point. Linda, and then Sri, if you wanted to follow up, if you did, go ahead, Linda.
So I think I'm hearkening back to some conversations that were happening about a year and a half ago. We've got some companies in the U.S. that do logistics fairly well. They're kind of known for it. And so the question that came up then was, why can't we know what therapeutics are available and where they're located, and therefore let providers and prescribers know where these things are and crosswalk them with what would be lagging indicators, deaths and hospitalizations. But if you know something's happening in a particular area of the country, can you make sure that these therapeutics are there? So if we learn anything from this experience, I hope we'll learn that we've got to come up with those data systems. And frankly, I think they exist. Use those data systems so that we can actually crosswalk the availability of therapeutics with need, and make sure providers know about this and have access to it, whether it's a great portal or whatever. But then we can find out what's actually happening, because we are all sort of assuming if they exist, they will be prescribed, and that's not necessarily the case. But we've got to do at least step one first, and then find out if disparities are actually happening during treatment.
Thank you. Good. Actually, Sri, let me let you go first if you want to, and then Jim, I'll catch you.
I'll be really brief. I do. The federal government and states have been incredible partners for us, for all of us here in the Roundtable. But I would say, it does create, the distribution system has created confusion, and we've done the same error over and over through the pandemic. And so, we had initial allocation to states, and then feds purchased, allocated to states. Each state could then determine the distribution. And there's something that is very helpful about having that local distribution. But when you're a multi-state operator, each state had a different set of rules. And so, in some states, it was directly allocating to telling which pharmacies should be stocking and which should not be stocking. Whereas others, it was given to that institution, and that group could then use their data to say, where do we predict where there's going to be uptake, and how can we get the product out there, or something in the middle. We did that for vaccines. We did it for monoclonals. We did it again for oral antivirals. And so I think in terms of distribution logistics, a lot has already been worked out pre-pandemic. And I think trying to get into the traditional chains as quickly as possible is good. I think Jim correctly pointed out, getting that procurement up front is really important. So at least we open up the access. Right. But then I think, trying to, get the distribution out with guardrails to make sure that populations are protected and are not left out is really important. But it's a safeguarding role, as opposed to, I think, being directive and saying, this is how the private sector should act. I think that balancing act is important. I think once the allocation can be purchased by private sector from a central store, then what you see is providers know how to access it, and you get much faster uptake of product. And so let's leave it at that.
Good. And we're coming right back. I tried to frame this as a kind of pre-scarce, allocation issues, and we're going to move into we've got enough, but we're still struggling to know what to do with it. So hold on to some of those ideas. Jim, please go ahead.
And it was actually time, because I'll build on what Sri was saying, right? So going back to the allocation being very different at the individual state level. I mean, one of the questions to ask after the fact, right, is which are the states that did it well, and which were the states that didn't do it as well? And part of the difficulty there is obviously defining what exactly does well mean under this scenario. The other thing would be curious as to who adopted along the way, right? Because the states have been involved in the distribution, again, of vaccines, of the monoclonals, and of the oral agents. And I do think there are some states that did a better job of recognizing, and Sri can speak to this, right, how CVS, an entity like they, got pulled into utilizing their retail stores to a greater extent in certain states versus other states. where those states were more comfortable with pushing the product into different locations. The other thing I just wanted to add to it is the role of education, right? And it's education not only on the distribution side of things in terms of the availability of the product, but we've all been circling around this a little bit, right? Education on the individual products, because one of the things that I would post is, certain products were available in much greater quantities than other products. But because of the way information was flowing out around the individual products, there may have been a bias in prescribing towards one, or a desire, whether at the patient level or prescriber level, for one product over another, when another product could provide a significant advantage and was readily available. And again, I think that was true whether you look back to the vaccines, whether you look to the monoclonals or the oral agents. I mean, I recall back in the days of the vaccines where people were saying, I want the X vaccine, I don't want the other one, when in reality, there's a significant benefit of any one of the vaccines as long as it's administered to an individual. There is no benefit to that individual if they get none of the vaccines because they're holding out for one. And the same can be said along that paradigm, right? So, again, I think it's important. A learning here is that if these products are approved because of the benefit that they can provide, then any benefit they can provide is better than none, right? And therefore, we have to be very cautious in who's doing the education and the messages that are being communicated around waiting for one product versus another. And I'll emphasize that very strongly on the orals, when again, you're looking at a very narrow window of has to be prescribed within 3 to 5 days of a positive test, right? So your window gets very, very short. Yeah.
Okay, this is great. Actually, and it feeds in well to moving into the kind of more current situation. And again, I guess I am over reflecting probably on what I've seen from the state of Massachusetts, but I did go out and looked at New York's and Michigan's and Tennessee's. I've looked at a bunch of different states. But one of the things I liked about Massachusetts was that they did make it really clear that for outpatient treatment, they didn't make you feel like you should just forget it if you can't get your top choice. They made it really clear in the structure of the information they gave that, you might consider this first, but if it's not available or there's a contraindication, you just go to this next one. So they made it pretty easy to kind of look at it that way. All right, so my note to myself says there was an NPR like March 18th, as opposed to scarcity. NPR had a story on March 18th, the headline of which was life-saving COVID drugs are sitting unused on pharmacy shelves. So let's turn to the current situation in which that's now at least one particular headline about this situation. And another quote to give you kind of a kickoff here, and we've talked about this before. This was from Dr. Cameron Webb, who's the Senior Policy Advisor for Equity on the White House COVID team. He said a high-risk person would have to identify that they have symptoms. They have to then get a test, find a test and get it, get the test result, contact a provider who can prescribe the medication, get that prescription sent over to a pharmacy where they can get it, and then go pick up that prescription. That's at least 6 different steps. And I saw some other quote that said, the management of outpatient treatment of COVID requires steps that would become a high functioning healthcare system. And so we know it's not going to work in the United States. So let's talk about test to treat. It is part of the formal national COVID-19 preparedness plan. It was started a month ago. It has several hundred sites, but so far I think that's it. And I went online again, and interestingly enough, the locator for test to treat sites is on another website. It's not NIH, it's not CDC, it's ASPR, the Assistant Secretary for Preparedness and Response. So out of the woodwork comes another governmental department that owns test to treat locating. And last I'll say, for what it's worth, I decided St. Louis, in the heart of the Midwest, I went to say, how many test to treat sites are there in metropolitan St. Louis? Anybody want to guess? 3, you own them both. 2 of them, 2 for metropolitan St. Louis. So test to treat, at least the formal aspects of it, if you use the locator, are struggling. And we have lots of issues we can talk about here, including the role of pharmacists in prescribing and other things. But given our current situation with quote unquote having enough of these treatments around, but they're not being used, and maybe it's still hard to line up all the testing to treatment aspects, I want to start with Linda. Linda, again, we can talk about all the tech that we can use and all the high flying best practices. what do we need to do to get this right for all the different communities that have been always struggling and, with access for anything. And now we get this new thing that requires all these different parts of the healthcare system to work together. What do we have to do better, and how do we get there?
So my first question, Steve, is how many of those sites were in East St. Louis?
I don't know. And that's my ignorance. I look at St. Louis and I say, you would probably
zero.
I don't know.
So, first of all, you got to have access to a computer to look this up. And so that already eliminates a fairly significant percentage of the population. Although oddly, people don't believe it, but in the rural South, it's not all that easy. But the other issue with this, and this was what I was trying to get at with my earlier question, is we put the burden on the patient. I've got symptoms. Oh, I wonder if this is COVID. Now I've got to go discover if this is COVID. Well, I've got to have the kind of job or life that allows me to go find out if it's COVID. To take off from work, perhaps, or go travel someplace, drive, or get there if I don't have a car. So we don't make it easy. And so what will happen, and what is happening, of course, is for certain segments of the population, they don't do anything. It's like, well, maybe it's a cold, it'll go away, it's not that bad, whatever, until it gets really bad. And now we're in a whole other space where the therapeutics we're talking about perhaps won't be all that helpful, if they're even available. So, I kind of bring this down to what the state health departments can do in terms of education and creating those access points, and then coming down to city and county health departments and what they can do to create those access points and disseminate information and make sure it gets down to the FQHCs and the community hospitals and the community clinics, because it is actually, I guess it's hard to believe that information is actually not making its way all the way to those providers in their single doc office or a couple of doc offices in rural areas. So we can communicate. Obviously, people can get information. We do know how to share information. We are just not doing a very good job of it.
Okay. Sri, I'm coming to you next, but I first want to ask Mohammed, who very fortuitously has his hand raised. So I was going to ask you probably what you wanted to say anyway, which was help us through how you're trying to make this work for a Medicaid population, test to treat.
Sure. So there's been a little bit of background turf war going on as well of should pharmacists be able to do test and treat? Should this be held by an MD-DO clinician? And we know that these drugs like Paxlovid has drug-drug interactions. For if you are on certain medications, they are considerable. But I'm going to bring in a little bit of my 2 cents on the table as well as my clinician input. I don't have an encyclopedic list of all those drugs, of all that P450 pathway. I look it up. And I don't know why a pharmacist can't look it up in difference to me as long as the patient is able to provide their medication list. So I feel like the more barriers that we can reduce for having more sites available at the front for patients, the better. And we should leverage our whole workforce to do that. I think any of the practicing clinicians in the room who have the ability to recommend Paxlovid or one of the monoclonals has seen the patient to whom they tried to talk into it, but they had to do 1 or 2 extra steps, and the patient said no. And the patient's making a personal decision, but you, the clinician who's seen all the negative outcomes, you're just struggling to say, if I could just give it to you now, it would be better for you. We have to remove as many roadblocks as we can.
So again, if we wanted to capture something that you feel you've either been able to do or you'd really like to do as a policy recommendation for the Medicaid population to make test to treat work for them, what's needed? What's best practice? What should we advocate for?
My 2 cents, I can't control how many sites we have across the state necessarily in my Medicaid hat, but I want to be able to pay a pharmacist or somebody at that front line who doesn't necessarily have to be an MD to be involved in getting those medications in patients' hands. I don't think it's rocket science. It needs some prudent cross-referencing and looking up, but it's doable. And we always talk about top of license. You don't need 15 minutes of 99213 CPT code Mohammed Dar to make sure you get this medication in your hands.
I even think Adarsh said earlier that I think, Adarsh, don't you say you work with a pharmacist in your practice to help you, kind of tease out which of these patients can manage Paxlovid with some of their existing medications. Let me go to Sri, if you don't mind, then I'll circle back to you though on this. So Sri, are you the backbone of Test to Treat in the United States? Is CVS? It seems like a lot of these sites are CVS, and I'm thinking that's because you have minute clinics where you meet the kind of legal definition of having a prescriber in the house who can manage the situation. Like, what's your organization's view on this? And again, it may be challenging because you have to deal with the laws as they are in each state around who can prescribe what, but how do you think you could suggest a better way forward for Test to Treat?
There's a lot there, Steve. Let me break it down a little bit. So, we're proud of how we've been able to stand up, across many of these aspects of the COVID response, whether it's vaccines, testing, or now oral antivirals. And so with the oral antivirals, as a reminder, the Test to Treat program is for retail clinics within pharmacies. It's not the pharmacists. And so, just to differentiate that out. And so it's our nurse practitioners in our minute clinics who are providing, review, evaluation after the testing. So CVS Health is providing testing across our fleet of stores, but then we have the ability to work with our minute clinic providers in the 1,200 stores. So we're providing oral antivirals, and now I think almost all of our stores, if not all of our stores, the Test to Treat, and we're doing testing in a majority of stores. And then we flex that up and down depending on how much of the pandemic is going on. And then on the testing piece, we have the ability to, with Minute Clinic, support whether it's your test that you received at CVS Health, or you're bringing in a test from an addition, outside setting, and our Minute Clinic providers can either in person or through an e-visit evaluate and do the prescribing. And again, we're on Epic, and so we have the ability to Mohammed's point to the drug-drug interactions, and we have the clinical decision support to ensure safe prescribing. I think what's the reality is that Test to Treat is going to be one component of the overall response for us to be able to provide oral antivirals. And I think we would welcome pharmacist prescribing, recognizing that there's a lot of competing demands on pharmacists. So we need to make sure that it's done in a safe and thoughtful way. But we have continuously advocated the expanded role of the pharmacist, whether it's Test to Treat or other initiatives. And then I would welcome comments from others about other ways beyond pharmacy. But we do think that pharmacy is an important path to Test to Treat.
Sri, forgive my ignorance. I probably could have figured this out on my own, but does Test to Treat in your centers, does it work such that a patient can come in, get the test, sit down for 15, 20 minutes and wait for the result? And if it's positive, go over around the curtain and talk to the nurse practitioner to get treatment prescribed? Or is
Look, it's all of the above, right? So in a Minute Clinic where we have point of care testing, you can, receive exactly what you're describing, get that testing and get treated. And then you can also bring your test results from somewhere else and have it evaluated and make that determination of, do you meet the criteria for treatment? So, and that somewhere else could be CVS Health testing, PCR testing that was sent away and comes back a day later, or it could have been a test that you did at another health system and are looking for access. So does that help, Steve?
Yes, no, it does. No, it's, I think absolutely. I think everybody would agree that it's best practice to have different options available for people.
Exactly.
But just thinking specifically about low income people for whom it's very hard to leave work once, if you can somehow do it to get tested and treated without having to make multiple trips, separate trips from your work or whatever, family, whatever other kind of responsibilities you have.
And we also do it.
I know that's really
e-visit as well.
And
we do both.
Okay. Yeah.
So we both do it online, and we can
Yeah.
as an e-visit, and you can also do it as rapid testing in our sites as well.
Okay, great. Sensitive to the time, but this is great. I appreciate it. Adarsh, let me go ahead and have your comment. Then I want to shift to talk about pricing and payment lessons to be learned. Go ahead.
Steve, hopefully I'll make it quick. Again, the whole idea of delivery of healthcare, COVID-19 was not the problem. It just brought out pre-existing problems. I think the problem is with our delivery system. I don't think I have enough time to talk about patient factors. From a provider experience, the regulations should change. Why should it be a human being when an app can do it? Right? It's very straightforward. I can go in and I can plug it in. If I don't have an app, just have a kiosk. And asynchronously, I think some places did. If you fulfill the criteria and you get the test, a machine is going to prescribe. Only if it requires human intervention can it be. And there's a lot of healthcare that can be delivered that way. We are in where artificial intelligence works. When I ask my pharmacist, she plugs it into Lexicon. She doesn't know all the drug interactions. Why do you need two human beings? What a machine is going to tell us what to do. I'm hoping healthcare delivery in the future changes where we augment where a machine can't do it. And I think that's using people at the top of their license and also using lesser human resources.
All right, thanks. Okay, top of the hour, 30 minutes left, which will include your guys' chance to make a final comment. So I want to talk about, again, lessons learned and perspectives on the pricing and the contracting, I guess, future negotiations as well. So just a couple of points, again, all from the public domain. Paxlovid, and I know Pfizer does not have a representative that they chose to send to participate in the policy roundtable, but through the Freedom of Information Act, NPR was able to see their contract and reported on it. So just to kind of set some of the context, their contract runs from November 17th, 2021 to September 2022. It was originally for 10 million doses, and then it was increased to 20, $530 for each course. There's a buyback clause if the drug turns out to have problems or other issues. There's a most favored nation clause, so that if one of 6 other wealthy countries gets a lower price, the US government also gets that price. And the report from NPR said that September 2022 is when the final doses should be released under that contract. So that may have nothing to do with the contract that Merck struck with the federal government, but that is what we know about the Pfizer contract. And it obviously raises interesting questions about things like the most favored nation clause, which some observers were surprised that the government got that. They weren't sure why Pfizer decided to give that to them, but they did. And as far as Merck, and I appreciate Merck being on the roundtable, I do. And so the Wall Street Journal reported that by early February of this year, Merck had delivered all 3.1 million courses it owed to the US government under a $2.2 billion agreement. And that was published in the Wall Street Journal on March 14th. So I have no idea, Jim, if you're at liberty or even know, you probably know, but you may not be at liberty. But is it publicly mentionable when your pricing funding agreement ends? We know Pfizer's ends in September 22. And I just don't know if it's set up so that the government can automatically renew it or if either party can. Can you give us any insights into what you know about either your contract or Merck's and how it's set up?
I mean, I guess what I would say is not really, Steve, other than what's been publicly made available. I guess the way I would characterize it is, it wouldn't be surprising for you to hear that, the terms and conditions are largely consistent, right, with what has been agreed upon. And once again, monoclonals may be different, but I would imagine there are similar timings to the terms of these agreements, right? Anticipation around this is, remember, the contracts were struck based upon a quantity of products we purchased for an intended population to be treated for a defined period of time, right? That was under an early use authorization. As with anything with the government, it would be very difficult to then go back and change those terms should there be an ongoing need and an extension of the pandemic and so on and so forth, right? Nor would that be, I don't think, the intent of any company. I don't want to speak, I can't speak specifically on behalf of Merck, but just broadly from an industry perspective, I think that would be the case. So apologies that I can't go into any great detail for anything that's not publicly disclosed, but what I would say is, terms around most of these agreements are probably largely consistent.
Got it. Yeah, I mean, the part, at least I'm sure many stakeholders are interested in knowing whether the government can decide to extend this or whether the company can say, nope, our contract was over, Pfizer's was over September 22, and we're ready to price on the open market. So even if you want to renew it, we're going to say, thank you anyway. That was not publicly reported, so I don't know where that stands. And I assume you don't know any more than that?
Yeah, I mean, nothing that I can share. What I would say again is remember that these contracts are struck under the context of the early use authorization. I mean, you just quoted some of the terms directly from the Pfizer agreement, right?
Right.
The buyback clause, that clause is tied to the early use authorization, right? There is a period of time with an assumption around an early use authorization. Once again, the intent for all of the companies involved in this would be to, provide the data to the FDA for submission for an approval of the product. Once that product is approved, right, then there's a potential for commercialization of that product. All of that is dependent upon, in this situation, right, what is the status of the disease at that point in time? What is the need for the product? What is the population to be served, et cetera, et cetera? So there's a variety of factors that are going to go into that, right? So again, remember, these deals are being struck as advanced purchase agreements as part of early use authorization, right? Those two are going hand.
Yeah. And you're suggesting that when full approval is obtained, that's one signpost when the agreement stops.
No, I'm not necessarily saying that, right? Because remember, I'll put it this way: it is my understanding, or my understanding is, if the product is filed and approved by the FDA, then there no longer is an early use authorization, right? And so if the deals are struck as a component of the early use authorization and the terms are tied to that early use authorization, then in theory, right, you would argue that there's no longer an ability to extend or anything like that, because there's no longer an early use authorization.
Got it. Let me read one other quote. This was in a Pink Sheet article from November last year. It was Pfizer saying, again, this was its statement about its pricing as part of this agreement. The pricing for Paxlovid is based on the principles of advanced commitment, volume, equity, and affordability. The price being paid by the US government is reflective of the high committed volume of treatment courses being purchased through 2022. And again, we're looking for kind of best practices or lessons to be learned. And I guess I could have said at the outset, the context being, at least from a cost effectiveness paradigm, these treatments are all priced in reasonable alignment with their benefits to patients, albeit all of the ups and downs with the course of Omicron and the different kind of background risks, and albeit some of the uncertainties that are always part of an EUA kind of package. The pricing, you could say, came out pretty good for the US public from a value perspective. And so some people would say that we got a good thing out of the government's involvement. And I'm kind of curious, when I hear Pfizer's statement, I hear advanced commitment basically twice. There's something critical about the fact that the government was getting involved early and agreeing to buy a fairly large amount of the drug at a set price. As part of the company, I think part of their worldview, I'm guessing, feeling that that was part of what made it a reasonable price. Any thoughts on that? Again, I guess, Jim, maybe I'm looking more at you than others because for the orals, you are the kind of person, but there were agreements on this with the monoclonals as well. So feel free to chime in if you'd like to. What are the lessons learned here? Is the lesson that we should have the government involved in the pricing, and this is exactly how they do it? They get involved, they buy a chunk up front. Is this a good model?
Wow, that's a very loaded question, Steve.
Good.
So I would say the model is unique to the circumstances presented by the COVID pandemic, right? So if you read the comments that's in that Pfizer release, it is tied to a volume. It is tied to an advanced purchase agreement. So it is an agreement in advance of a product approval for a product for which you don't necessarily know or understand what that approval will be. You don't know and understand what the approved population, indication, utilization, et cetera, will be. You don't know what the ultimate utilization of that product will be based upon how it will be received by prescribers and by patients. So there's a significant risk component to that. And that's feeding into, right, how you are negotiating, discussing, and ultimately finalizing that contract. Keep in mind, there's also a part of that, and I'm going to keep going back to, and I welcome Mary and or Mohammed into the conversation as it pertains to the monoclonals, but even back to the vaccines, there were significant outlays by the federal government. Why is that? To de-risk investments that were being made in either, I should say, either or, and maybe it's all three, right? Both of these, the clinical development and or the manufacturing to have product made available as quickly as possible following those early use authorizations, right? And so you have to balance all of that. That is a very unique situation. In other situations of product launches, it is the manufacturer that bears all of the risk in the clinical investments, the development of that product, the manufacturing scale up, the inventory builds, everything is borne by the manufacturer in those situations. And these are all things that you have to factor into the totality, right, of how we bring our products to market.
I'm glad you mentioned de-risk. Oh, I'm sorry, Mary, please.
No, I would just, echo what Jim said. I think the investment upfront to bring this innovation for the treatment of patients is significant. And I think having the federal government, take a leading role in that, was of great benefit to the patients that were able to receive those treatments.
Mohammed, I'll give you a shot too.
Absolutely. I mean, Jim just very well said. I mean, it's all about investment versus risk. And despite the fact that over the past decades, for example, Regeneron have developed a platform for monoclonal antibodies that has allowed us to respond very quickly. The fact that the government was able to negotiate a pricing contract with all the unknown about the product itself, not the platform, but the product, was very helpful to bring this treatment to the patient in need very quickly. So this model is very welcomed in a situation like the one we have faced. And as Jim said, it's a very unique situation and it affects so many people in a very short amount of time.
Yeah. Jim, thank you. And for all of you, thanks. The Pink Sheet had an article titled, "Did Merck Drive a Harder Bargain? Your drug, yours is a $710 per course and Pfizer's is $530. And again, Pfizer listed the components of its thinking publicly about how it would price things. Are you able to comment at all on whether you guys were better negotiators or what happened in terms of why you were higher priced?
No is the short answer, Steve, because I can't comment.
I knew you wouldn't, but I had to ask.
I can't comment on what went into the conversation and or negotiations to justify support the pricing, right? And the agreed upon price ultimately for each of the individual products that go across companies. I would imagine the pricing for monoclonals was not the same. You can look to the vaccines, again, the pricing is not the same. So these are all negotiated, quote unquote, prices, right, with the federal government. And so it's based on a variety of factors that go into it. And how the government evaluates that, right, is entirely independent to that negotiation or that discussion.
My takeaway from the Pfizer comments and from other conversations, actually I've had conversations with people on the board of vaccine makers, not necessarily involved in this meeting at all, who stipulated that one of the reasons why government negotiation and a contract like this, an advanced commitment, it's helpful is you use the term de-risk. There's de-risking because you're covered for your research and development and to a certain extent your manufacturing costs. You're also de-risked from the evolving landscape. Let's say suddenly COVID goes away. There were times when we were still thinking, remember, at least public officials were saying one day we'd wake up and it would be gone. And so if you have an advanced market commitment, you've actually covered yourself from that risk as well as other kinds of risks. So it is a very unique situation compared to other treatments for more chronic and certainly persistent drugs, conditions, although this may be ultimately that type. But I'm struck by the fact that the government in its negotiation, again, if I had to say what could be policy kind of best practices, it got out in front. It obviously negotiated in a way that established enough de-risking to get not just one, but multiple treatments available, not knowing what the variants and the course of the disease would look like. And it seemed to do so in a way that met certain standards, at least of value and likely affordability ultimately from a societal perspective. Does anybody see anything that could have been done better in the way that the government handled this? How often do we have that question asked and no one can think of something?
So in terms of what, Steve? In terms of what?
In terms of their approach to pricing, contracting, the timing, the amount, the approach, any guidance on thoughts on ways it could have been done better. Certainly it hasn't hurt the private market to feel like their treatments are free, right? I mean, for doctors to be able to prescribe something that's free to patients, that's great. For health insurers and employers.
I mean, it's not free, right, Steve?
Well,
like there's a dispensing fee, there's an administration fee. So, you know, we still see that these therapies have substantially increased overall healthcare costs just from the administration fees. So, you know, once you add the ingredient costs, you know, we will see, you know, another increase in health benefits and pharmacy benefits. So,
good point.
I think to answer your question, I can't. I don't have anything that I could specifically say on the procurement side. I think it's the conversation on distribution that we had before, which I think is where we have a lot of lessons learned.
Yeah.
But on procurement, I think it's a necessary first step.
Who's going to go?
The one.
Yes,
sorry.
Mohammed.
Go ahead. No, just the one thing that I just want to say, it's important to put things in context, that our agreement with the government wasn't born only during the COVID-19. It was before then, like starting in 2017. We have actually an agreement with BARDA to eventually help in working on the development for 10 pathogens that pose significant risk for the public health, starting with influenza, and COVID-19 was added to that agreement. So it's actually pre-planned ahead of time, even prior to COVID-19, this type of involvement of the government that eventually de-risk the process for threats that eventually face the nation. So that's what I just wanted to say.
All right. How would you guys respond if I had somebody else on the roundtable from Public Citizen, let's say, if I had asked that question about what the government did, could something be better? They would say, absolutely. The government, because of their investment in the early research that leads to most of these treatments, should have struck a much harder bargain and should have made it very clear that if they had, the federal government had an important role in funding the basic research, that the cost would be much closer to the cost of production plus an incremental profit than anything that would, you know, kind of reflect a value price. So that's what they would have said. And what would you think a fair response? What would your response be to that perspective?
I think the elements of. Go ahead.
Go ahead, Mohammed, and we'll go around. Oh, okay. Who wants to go first, Mohammed or Sri? Mohammed, why don't you go first? Oh, no, okay, Sri, go ahead.
Okay, so I'll go. So, you know, I think that is a fair argument. I think what's important is that we have a rubric or a framework of how to actually negotiate around that construct as opposed to trying to create it in the time of a pandemic, because it's not really specific to just our response to COVID. You know, you could argue that for many therapies, the investment that the federal government has made in basic science research that led to those therapies being discovered it could be across multiple areas. But we haven't agreed on what's the construct or framework for what that public citizen type of comment would be and how that flows through. So I think it's just, my point here is it's not COVID exceptionalism. It's true across therapies or not true across therapies. We just have to agree on that.
Okay, let's get some other comments. Mohammed, do you want to go next?
Through this, I'm curious.
Mo has his hand up, but let me see if let me have a quick comeback from Jim or Mohammed, and then I'll go to Mo.
Sure. I mean, I was just saying, Steve, this is exactly why we're having the conversation we're having right now. And if that same public citizen attended the earlier session that you've presented on the economic model and the value of these products, I think that question would not come up, because we have already, and you've done a pretty good job on establishing frameworks by which we can evaluate the value of the product to the society, the value of the product to the healthcare system. So if we were to, for example, find that the current pricing falls out of these norms that we have established or frameworks, then that could have been absolutely an issue. So I think if you look across the board, and we read your report very carefully, you'll find that almost all of the treatment that have been evaluated are found to be very valuable and fairly priced based on the frameworks that we have.
Mm-hmm. Agreed. Okay, I'm actually now noticing the time and the time I want to leave for you to make your final comments. So Mo, I know you had your hand up, but I wanted to shift to a couple questions about the future and negotiating and formularies. So Jim, can you be real quick and go ahead?
I will be real quick, because all I want to say is one thing I would respond to the public citizen, right, is you can't look at the de-risking of a single compound and or the construct of a contract and value of a single compound in the absence of all the other investments that are being made. So when you look across the industry, substantial investments were made, Merck included in this, to try to investigate and develop very quickly vaccines for COVID, monoclonal antibodies for COVID, oral medications for COVID. Not all of them came to fruition. Not all of them had an advanced purchase agreement, and not all of them had any investment from the federal government. And so you can't take this and say this just goes down to the cost of the medicine, right? Those investments are made with, those revenues, I'll say, are reinvested with purpose around all of the things an individual company does, as well as the industry, right? So you can't take that just in.
Yep. I actually think somebody ought to do a good little piece on all the rubbish heap of treatments and vaccines that didn't make it through, to kind of see that larger iceberg, if you will. Okay, let's talk about the post-government phase, whether it's September 22 for the Paxlovid or not, and whatever it is for the Merck drug. So all of a sudden, Sri's gonna, or his minions are gonna be having conversations with people from Pfizer and from Merck about these oral pills. And Sri, I guess I'll ask you first. Do you feel likely that you will have any negotiation role? Will you just say, what price do I pay you? Will you actually think of a formulary in which you will step patients through these? I mean, what's the process going to be through which you and your team think about that phase when it's coming?
Yeah, first off, friendly amendment, they're colleagues, not minions. But with that said, I think again, it's not COVID exceptionalism, right? Like when these come into the public, into the private markets, like we start with clinical integrity. All I can do is speak from like the CVS Caremark perspective or the Aetna Health Benefits perspective. We are looking at what is the clinical evidence, and is there enough evidence to determine whether or not there's equivalency or is there a superior product from an efficacy and safety perspective. And then that information is then fed through our formulary processes with our National P&T Committee, which is an external body, 17 clinicians of various backgrounds. And then based on that determination, we can use, and we work with our trade negotiation team. Mm-hmm. So if there is no evidence that one is superior over the other, if they're at equivalence, that creates an opportunity for market competition. And we may not decide to limit the formulary for other reasons. And these are complex decisions that go into that. But if there is evidence that there is a superior product, then that leads to a different set of negotiations. So it all starts with the evidence that is out there. And I think Ed in his opening comments and talked about the need for that evidence when we get to this stage.
Let me move at light speed here. Let's assume that Paxlovid is determined by your P&T committee to be superior or the best in class. So you can't exclude it. You can't step through something else to get to it. Now you're facing a manufacturer who holds a lot of cards, right? Because you have to say yes. How are you going to manage it, the price? I mean, obviously they don't want to be in the headlines for charging you 10 times what they charge the government, but on the other hand, maybe they will charge you a fair amount because they know you can't walk away. Would you be trying to come up with an advanced market commitment for them as a payer? Are you big enough to say, hey, instead of us paying you so much each pill, why don't we come up with something similar to what the government did with you and come up with an amount of doses for a fee right now, and you'll get that money one way or the other? And I mean, what would you consider as options?
Yeah, I mean, I don't think there's nothing specific around oral antivirals compared to any other medication or decision that we'd need to make. That I would say when there's competition, clinical competition, that's when we get the ability to have price to work on price. When there isn't, it is harder. And the model that you described would be unlikely.
Just because of the risk to you, or you don't have the scale to offer that kind of contract?
I think I would say it's more the former than the latter. We have the scale, but just because you can't, in the end, we're trying to make sure that we are providing adequate access to necessary therapies and maintaining costs. In that model that you're describing, it's not clear to me that necessarily would reduce costs. There's a lot of risk to that, and it's not clear what benefit that would have.
I love a world, this idealized world in which it's in everybody's best interest for these pills to get to the patients who will benefit from them. And so it's just interesting to think about whether we will ultimately enter a world in which there will be some hesitancy or desire to restrain the use of these to quote appropriate patients, kind of like happens for everything else, as opposed to a public health emergency situation. Mo, I kept you out the last time around, and so let me invite your comment here.
Sure. In trying to determine what the future model can be, I want to take us back to groundbreaking, but very expensive drugs of past, when Sovaldi and Harvoni hit the market, for example. Could you imagine if that was a COVID breakthrough? One drug hits the market ahead of many. The price is set at what it would take to prevent an ICU stay at a hospital. And then every payer is suddenly kind of brought to their knees trying to figure out what is the prior authorization criteria for a narrow set of patients to get it. And if that had been the outcome instead of where we've been today, a lot of cost gets pushed on to the patients, or they get denied by the process. And I live in the Medicaid space where we are trying to increase access as much as we can, but we're also trying to be a good steward of the public dollar, ever struggling with new drug development and what that means for programs that we do for Medicaid patients. I can't tell you exactly what the best future program is, but the old system doesn't serve us well either. And it's ultimately the patient who gets denied one way or another, and we don't notice the ones who get left behind all so often.
Jim, maybe I can ask you the last question before we move to your comments. So on your end, you're marching in to talk to the Sris of the world. And would you be open, or do you think you're already thinking of either subscription style agreements or something else that feels different than the standard price per pill with prior auth kind of considerations? Is there anything that would be best practice if we want to maximize the use of these pills for the appropriate patients?
I mean, I guess what I would say, Steve, is I don't know that there's necessarily one right answer, right? So, in a broad context, when Merck is doing pricing for our drugs, right, we consider what is the value that the product can bring to the population? What is the value and or the offset, right, within the context of the broader healthcare environment? How do we ensure that there's broad access to the medicines to the patients who need them, right? And so you begin to try to address those issues when you think about the pricing of your products. To your question around a specific way, I mean, I think every company in the industry would prefer to go down the path of more innovative approaches to this, right, from an access perspective. bringing more pricing aligned with value. The challenge is we have a very complex healthcare system. I mean, Sri alone, right within the CV Health umbrella, has a multitude of components that are all interacting with each other. He has a constituency on the employer side, right, in terms of benefit design and other things that he needs to satisfy from a customer base. And then we can get into where the data resides, right? Where does the data reside in terms of the prescribing and the cost associated with prescribing, and then the medical offsets around hospitalization and other things, as Dr. Dar just referred to, right? So the notion of how do you get to a single price that's absolute and across the entirety of the market is very, very complex. And it involves multiple constituents, multiple individuals and or entities who hold access to differential data that it takes to reconcile all of that. So I don't know that we're necessarily there now. I think it's a direction that we would like to be able to head into, and I don't know that we're going to solve it by the time we have approved products for COVID, whether Merck or any of those that are currently under early use authorization. So not a good answer, and I'm sure not the answer you wanted to your question, but at least it's a transparent answer in terms of the complexity that we face every time we bring a product to market.
Now I can only imagine the complexity of the shift from the governmental phase to a private market phase is going to be unbelievably messy and interesting in its own way. But again, maybe that will offer some opportunities for some innovative approaches. I'm sure Mohammed Dar would appreciate a supplemental rebate. Sri might appreciate a Netflix approach. Who knows? But we're going to be entering interesting times, again, depending on where COVID is as well. But let's assume things are kind of the same. Later this year might be the phase in which we start to witness some of these shifts occurring. All right, fantastic conversation. I apologize for the brevity with which we had to treat a lot of the issues and your comments, where we could have really spent more time usefully exploring kind of perspectives that you brought to the table. And the last thing I'd really invite you to do, though, is to have a final comment. We invite people to actually try to make it as a one-sentence final comment. You're allowed a comma, a well-placed semicolon, perhaps, but if you can try to keep it brief, we'd appreciate it. And often I suggest it can either be just one theme or one fact or one issue that you want to make sure that we've heard again and comes away as a very strong takeaway point. It can be a request of a stakeholder at the table, or even one like the government who's not, something that you think if we could have one thing done by that stakeholder that would make the world a better place going forward, I would ask this of them. So those are just two options for your final comment. And I'd appreciate your thinking about that. And I usually like to end with the patient perspective. So Lindo, you'll go last. And why don't I invite the payers to go first? So Mohammed, why don't I ask you to go at this point and have a final comment, and we'll run around the circle here.
Sure thing. I actually was going to anchor a bit to the patient perspective. I would say that each of us here in the room should think about someone we know who noble, kind, but not good at navigating complex systems, not able to navigate this kind of healthcare system. And are the things we are doing serving that person? Because there are millions and millions of them. And we have complex problems, but the onus we have to do right by them is more important.
Thank you very, very much. Sri.
Yeah, something similar. Procurement, distribution are challenging, but the most complex across all of this has been the last mile challenges. We need to keep thinking about that.
Okay, thank you. All right, Mohammed Hussein.
Yeah, sorry for the confusion, because we had two Mohammeds on the call, and usually it's a very rare event. So I must say that we believe that treatment diversification is essential for successfully fighting the COVID-19, and especially for patients that will continue to present with unmet medical needs, such immunocompromised patients and underserved populations.
Great.
That's all what I can say now.
Thank you very, very much. All right, Mary?
Yeah, I think, we're continuing our ongoing development program, which includes company-sponsored and investigator-led studies exploring areas of continued unmet need, which we talked a lot about as the pandemic continues to evolve, and trying to bring the best treatments for patients.
Thank you very much. And Jim, where'd you go?
I'm right here, Steve. So
oh, there you are. Sorry, right in the middle.
I'm going to try to achieve, but I'm going to try to achieve your one word, but I'm going to use the hyphen, right? And I'm going to say, I would just anchor it all in patient focused. And I think that's a theme you're hearing from everybody, right? And I would put it kind of in three categories. Mohammed hit it well in terms of choice, right? Multiple options are necessary. There is no one size fits all here. The second, I'll link to Linda, and so I'll tee up, I think, where she's going to go. So hopefully I don't steal your entire thunder, Linda, which is broad access, right? And broad access just doesn't mean it's out there. It means every patient who needs it, particularly communities that are more disparate in terms of care access. It's critically important that the access is all the way out there, as well as on the payer side of things, right? Which is the affordability aspect to it. And whether that's trying to address the patient out of pocket, whether that's free that does it through benefit design, or whether that's Merck and the manufacturers who try to do it in terms of ensuring lowered out of pocket patient costs, right? Or quite frankly, the government has a role in that as well to try to lower patient out of pockets. Those to me are the three components, and they all come back to that patient focused or patient centered.
Thank you very much. All right, Ed, what would be your final takeaway for us?
Yeah, I have a slightly different take on it. I don't think we did a great job. I think we have to really assess what has happened in the past and think about what worked during this and what didn't work. And, for the things that did work, perhaps a greater emphasis on them, but an acceptance that an awful lot of what occurred didn't work, was slow to occur. And ultimately, people died that probably didn't need to.
Okay, sad, but definitely true. Adarsh.
Yeah, I think I already spoke too much, Steve. So I'll pass it on to someone else.
Okay, feel free if you have a final inspiration to come. But Linda, please share with us your final thought.
Thanks, Jim. You did not steal my thunder, but I appreciate your comments. I would say let's not make this the patient's burden. Let's make access to information, testing, therapeutics very easy. Let's put it in the way so patients literally have to trip over it. Let's make it really easy for them. And let's make it really easy for their providers to treat them like they're their closest family member. Whatever they do for that family member, let's make it easy for them to do it for all their patients.
Great. That is a future I think we could all fully get behind. All right, on behalf of the Midwest CEPAC and ICER certainly too, let me thank you guys. That was a fantastic roundtable. So many issues again that we got into, but this special assessment may have a different iteration going forward. We'll see where we are with COVID in a year's time. ICER Analytics as a platform will allow us and others to kind of update it as further evidence arrives, and we can kind of all watch that process unfolding. But we do have a lot of lessons to be learned, both good and bad. And so I hope we can capture some of these in a useful way as part of the report. But thank you again very much. We really appreciate your participation. You're welcome to stay, or if you have to go, that's okay too. I'm now going to hand it back over to the chair of the CEPAC to let each individual member of the CEPAC have a parting statement. So Reem, back over to you.
Thank you, Steve. And thanks to the outstanding panel and the really wonderful discussion. This was quite informative and really good to hear. I'm going to go with the CEPAC members as they appear on my screen. So that's going to be more random, starting with Stuart.
Thank you. Thanks to ICER for this meaningful, timely, challenging episode of your work, and we are honored to be a participant. I just want us to look carefully at some of the delivery issues that have been touched on beautifully and the resultant access. I suspect retrospectively we'll find out we might have been wanting in that delivery of these drugs. Thank you.
Thanks, Stuart. Aaron?
I'll just say what I feel like I almost always say, in that I completely value this sort of open and honest dialogue, and the fact that we try to tackle these problems together and in the light of day. And I feel like that's the only way these kinds of issues are going to improve.
Thank you. Heather?
Well, first, I just want to say thank you to everybody. These experiences and these opportunities for me are just so invaluable and such a privilege. So I do want to just thank everybody, particularly those who presented today. And I think that this is, of course, a very timely, relevant, critical issue, but I think it also really drives home again, this aspect of balancing clinical effects and value and so forth against the social and lifestyle context, and who has access to care and who doesn't, and what can we do about that, and how do we value that? So just thank you, truly.
Thank you. Stacy?
Thank you. I love the comment about wanting people to have kind of information that they were tripping over, but it feels like we're nowhere near that. And so I think just considering how I'd like to see these drugs be used judiciously and equitably, it feels like our system is just not set up for that to happen. I hope it will, but I am a skeptic after so many things that have been inequitable in the pandemic.
Thank you. Tim?
Is that me?
Yeah.
Thanks. And I just want to thank the ICER staff and consultants and everybody for a great meeting. This ended up being more nuanced than I might have thought when I first read all the materials. I just want to echo some of the comments that people made. I'm going to pull out a quote that said, COVID's not just the problem, it brought out existing problems, somebody said. And, we were having a pretty active chat during the comment period about the access issues, and I won't reiterate that, but I will point out an additional one. We have a sort of broken public health system with regard to local and states not communicating well with each other, and I think we need to work on that too.
Thank you, Tim. Kurt?
Yeah, I don't have a whole lot to add. Obviously, access is so important. And I think it is unfortunate that the EUAs for Paxlovid and Molnupiravir specifically excluded pharmacists from prescribing these medications. And so again, access is very important. I appreciate the conversation by the panelists, particularly as related to pharmacists. But for all of you that to participate, I appreciate that. And I also just do a quick call out to the ICER staff, because this report today looks a lot different than what it did even last week, because sotrovimab was part of it. It was taken out. So I know that there was a lot of heavy lifting. So thank you for all that work. And that's it. Thanks.
Thanks, Kurt. Jill?
I would echo exactly what Kurt just said. Also, Timothy. Thanks to everyone. In addition to the CEPAC, I think the stakeholders today really rounded out and made the conversation very rich, made me think about things that I wouldn't normally think of as a pharmacist. And so thanks for including me.
Thank you. Eric?
So once again, Midwest CEPAC proves that calm, thoughtful dialogue about a difficult issue is possible. Who knew that we could get all these people together to talk about COVID-19 and do it in such a rational manner. So it's always an honor to be part of this group. And I think this is an interesting case in which we all bring personal experience with high risk or low risk people that we know, who had COVID-19 and who could have been candidates for these therapeutics. That's not always the case when we talk about these types of treatments. So anyway, just want to say thanks again for such a high quality experience, and thanks to all my colleagues on the CEPAC.
Great, thanks. Sneha?
Yeah, thank you so much for today. Really enjoyed the policy roundtable in particular. I just think two comments I just wanted to make was one, echoing the patient representative. I think there's a lot of burden that's placed on patient advocacy groups and patients to be educating and working with community partners. And as not only a patient, but as someone who runs a grassroots patient advocacy group, it is really hard. We get a lot of questions, and it is not as easy as just simply informing people. There's a lot of barriers with trust, a lot of sort of traumatic experiences with the healthcare system. And so I think that's something that we have to recognize. And so it's not as easy as just sort of access. There's a lot more to that, and really bringing in the health literacy component. And the second thing is just really emphasizing the importance of taking adverse events very, very seriously. I think that's a topic that, just as a patient, I feel like has been, not necessarily today, but in general, has been brushed over as, only X percentage of people have an adverse event. But unfortunately, those adverse events are truly transformational for patients. And I think a lot of times are very underreported, due to a variety of barriers. But so yeah, those are sort of the two things that I hope to emphasize today. Thank you so much.
Thank you. Don?
Yes, thanks to all. This has been fantastic, and thank you to the Policy Roundtable. That was really excellent. I just want to confine my comments to the discussion on guidelines, of which I've been involved many times. And I will say that we're still living above the line of what someone called the last mile when we talk about guidelines, because we start with the what and the why, and then we stop and we don't think about the how and by whom, or the so what. So I think implementation science is the second part of guideline development and implementation. And we need to evaluate the subsequent impact. There's an assumption that, if you build it, they will come, but that we know in reality isn't true, having tried to implement. I think, Steve, the best example that ICER has of this is the excellent work it did on evaluating the effectiveness of the digital apps for opioid use disorder, which brings in this whole other level of sort of digital health. And I know that you may not be aware that CDC and HL7 are working very closely now to congeal the informatics group with the guideline group up front so that these issues can be focused on the last mile. So I think we have to stop thinking up here above the last mile and get down to the nitty-gritty of doing the evaluation there.
Thanks, Don. Rachel?
Sure. So I echo all the thanks of the ICER staff for their work and the innovation voices who were able to join us today. I think today's discussion was harder than some that we've had because of the real changes in the evidence base and the conditions over and the way they've changed. But I want to say that I feel hopeful and optimistic. I hope we all do too, to be in a position where we have so many treatment options, also prevention and testing. Although today's meeting, I think, really does emphasize that there are opportunities for improvement.
Thanks, Rachel. Ingvar?
Yeah, thanks so much for having me. This was a great discussion. It really occurred to me that, when we originally looked at all the data in December, it was a very different world, and it's only 4 months later. It's good to review the data again. It's a moving target, and this is what we have to get used to. This is not how we usually do, guidelines and assessments that we have to change every 4 months, but this is something that we need to get used to. So thanks again for all the great discussion.
Thank you. I believe I called everybody, so I'll go last. I want to thank ICER for again bringing us together to have a civil discussion targeting very difficult issues, and really want to focus on 2 points. One is we know that long COVID is going to be an issue we have to deal with, and that will require rethinking about the outcomes we're assessing, and that we have to involve patients in these outcomes discussions. But more importantly, I know that the events rate are becoming low, but we don't want to swing to all outcomes that are not important to patients either. So we need to have a very structured discussion about that and make sure these outcomes are validated and continue to inform us. And I just want to highlight, just as it is quite challenging for patients to find the right information, it's unfortunately quite challenging to physicians at the front line to even keep up with the information and what's happening and what's required. And so there has to be some solutions or systems that are actually reliable, that feed this kind of information to patients with avoiding conflicting messaging. And I don't even know how to do that, but COVID uncovered all these issues to all of us. Thank you all to my fellow CEPAC, Midwest CEPAC members for your thoughts, insights, and questions. And it's been a pleasure and honor, as usual, to be with all of you. Steve, back to you.
Thank you, Ram. It's very gracious and lovely comments, everybody. My own brief reflections, like Don, I cut my teeth, making guidelines when guidelines were the new bright shiny thing that doctors hadn't done before, and we thought it would solve all of our problems. And you very rare, I can't tell you how many times I was in a room when guidelines were either just basically a food fight among uninformed doctors, just telling people what they did and why that was the right thing to do, or people who tried to do a systematic review, brought it back into the guideline room, and everybody just said, that has nothing to do with reality. That is completely divorced from everything that we need to talk about today. And so we weren't here to make a guideline today, but in a weird way, this was one of those meetings where there was the evidence, and then there was this huge gaping need for connecting the evidence through to the healthcare system that we just do not do well. And again, back to Ed Mills's comments, it's just so many places where we recognize and should recognize that we just didn't either have the right infrastructure or use the infrastructure that we had very wisely. And that's okay. Every once in a while we have to learn by making mistakes, as long as we're willing to own up to them. So I really appreciate the participation of all of you in looking through the evidence and in judging it in the way that you do, in a very transparent, open way, because that alone continues to be incredibly powerful, though, for the US healthcare system and others, to have you be able to talk through the evidence in a public forum like this, and to take votes that will express relative views of strength and weakness, limitations on the evidence. That's powerful. And yet, I guess Sri's comment about the last mile, I had to feel like everybody sees a different last mile, and there are so many of them. It just feels like the last mile getting evidence from clinical trials through to regulators, from regulators to payers, from payers to providers, or all the way from clinical trials to providers. Everybody's got different last miles, and then ultimately the one to the patient, which is always where we have the greatest risk of stumbling in our healthcare system. So we do have a lot of work to do, and we'll have to see over time how our role, ICER's role, evolves in this area. Again, we have people making guidelines, we have a lot of things going on, but it could be, for instance, with, I'm sure, a brand new set of treatments to consider, and I'm sure a completely new coverage and pricing landscape after we emerge out of the government contract phase, that there will be additional questions about evidence and value that we might usefully pick up and take forward. So I'm not sure we'll do that. We'll have to wait and see how the landscape evolves, but I am sure that your contribution today, the Midwest CEPAC's contribution, is an important point for many, many policymakers. So we'll do our best to capture the richness of this policy discussion, along with the votes and some of the insights into the evidence. And our final report usually comes out about 2 weeks after this meeting. And so we'll also have the ICER analytics platform ready to roll for people at that point who will already, I'm sure, be eager to update it and look at different ways to analyze the evidence. So thank you again for all your participation today. Ed, I see you're still on the call, as well as Adarsh, at least he was. Thank you, guys. Stalwart clinical experts, you guys have been with us for a long way through this journey, and we appreciated your participation all the way through. So thank you again. And Linda, if you're still on, I could thank you, but I think she's left, so I'll catch up with her afterwards. Otherwise, thanks for watching, and we'll see you at the next ICER meeting.